You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Joining me on today's show is Erson Religioso, a physical therapist from Buffalo, New York, who has seemingly done it all. Has been taking continuing education beyond his physical therapy program for the better part of the last 2 decades, teaching continuing education to DCs, PTs, ATCs, everybody in the conservative musculoskeletal realm, and now is taking the eclectic approach, as he calls it, to integrating as best as possible all of the ideas and all of the overlapping ideologies and first principles that have permeated our profession for the last maybe 50 years. And I think he's doing a pretty good job. Very interesting conversation that was wide-reaching, from how he got into the world of physical therapy, how he has developed his own clinical intuition, what he is doing with most of his time now, both in the clinic and outside the clinic, and down to what superpower would he pick if he could pick one. I think you're going to get a lot from this show, and I will put all of the links to the many things that he is involved with in the show notes. And without further ado, here is Erson Religioso. That's what I was going to say. I kind of started looking through everything, and I was like, holy cow, this guy is in a lot of stuff, which we'll talk about. And then you kind of been all over the place in terms of shows and media and doing it yourself. I didn't realize how far back the Untold Physio podcast, like you guys have podcasts clear back to what, 2018 or before then?
Well, before then, but before that I was on a show, like one of the first PT podcasts called Therapy Insiders.
Yeah.
And that was like, that goes back to maybe 2015 or 16, but I've been blogging since like 13 years. I used to blog every day. I was one of the first PT blogs, and that's kind of like the majority of my audience, even someone like Capo meeting me through my blog, because like there was nothing else to read back then.
That's how I knew about you. So I knew about you from when I went to chiro school at Logan, because I started in 2009, graduated in 2013. And yeah, that's the first time I heard about you. And correct me if I'm wrong, but my memory, maybe that's getting worse with age for things like that, was that's when you were heavily involved in like ISTM and kind of bringing some of your tools to market at that time, correct?
For sure, yes. Yeah, that was Mike Reinold and I developed the ISTM course, and that kind of exploded. The funny story about that is like I developed that tool because a chiro brought the Grasson tools into my clinic, and I was like, oh, how much are these things? You know, and I wasn't like working for myself or anything like that. I was just like someone's employee, you know?
Yeah.
And he's like, oh, they're $3,000. And I'm like, what, man, who's going to pay for these things? So I went through various iterations, various patients were metalworkers and everything. Then I had a student who helped me design it on CAD, and I presented it to various manufacturers, and I started trying to get it off the ground, and no one would listen to me. I was like reaching out to like the 5 PT influencers that I knew, who are like Mike Reinold, Charlie Weingroff, all these kind of like old school names, you know? And they were like, no, we don't know you. Like, why would we share your stuff? And I was like, well, I guess they have a point, you know, other than it being rude. I mean, you didn't even look at it, you know, like the least you could do is look at it. So I started creating so much content only purely based around the tool, because all I wanted to do was sell tools. It didn't occur to me that people would want to hear my voice, or people would want to take my courses or anything. And then just as many people started being interested in my courses. And then I kind of changed my whole approach. I got invaded by a bunch of evidence-based physios, maybe changed my whole approach, and that kind of is what became modern manual therapy and the eclectic approach. Is what.
Well, man, this took a different turn for the intro, but now I'm interested in all this. So back up a second there. So you said that you kind of got invaded by this evidence-based chiro group or physio group. What was
They weren't even physios. They were like they're PTs, massage therapists. Some of them are just like yoga, like lay people who are just like really. Like, they were the first evidence-based trolls.
Yeah.
I would say. Everyone hated them. And it's funny, too, because when I first started teaching, I would go all over the world. You know, South America, Canada, Rome, the Philippines. Like, wherever I was teaching, people were like, oh, yeah, I hate this particular group. Because that was their mission, was to bring up rehab, but at the cost of actually being a-holes.
Yeah.
Like
Yeah.
they wouldn't say, hey, you know what? You should think about it a different way. Instead, they were like, "You're a dinosaur. You're holding the profession back. Here's like 100 articles why you're wrong." And so immediately you go through cognitive dissonance,
Yeah.
And then one of these days when I'm like typing and typing and typing and typing, and I'm like being a keyboard warrior, and I'm like arguing at 1 a.m. My wife's like, "Why don't you just come to bed?" And I'm like letting this consume me,
Yeah.
because I'm not used to being trolled. Like no one likes being trolled. Now I'm kind of like when someone reaches out to me and they're like, "I'm thinking of getting into social media." I'm like, "You better have a thick skin." Um, I kind of started reading the articles, and instead of actually like ignoring all the ad hominem attacks, that I'm like a dinosaur and everything, I started looking at them critically. I was like, oh, I think they're right, and I'm actually wrong. So I think I do have to not necessarily change the way that I do everything, but maybe change the way I explain and present everything,
Yeah.
and tell patients why things work, and also tell other clinicians to tell patients to change the way that why things work.
I think that's a great thing to bring up, that if the approach would have been different, you would have had a more open mind maybe from the beginning, instead of, bristling against it, and maybe been an ally of the group instead of kind of coming to your own terms with it. So how long ago was that?
And I want to say I was only maybe a year or two into blogging, and like I had already started blowing up. So like popularity also irritated them. You know what I mean?
Yeah.
They were like, if only Erson would write this. And then even when I started changing, they're still bashing me in their
Can't
forum,
win.
because like they had their own forum. It wasn't even like a Facebook group or anything. It was literally like a forum. You remember like a forum, like a messaging
before Reddit?
website?
Yeah. Oh yeah.
Yeah, before Reddit or before Facebook groups or
Yeah.
LinkedIn groups, there was like website for you listeners who like maybe don't read things anymore and just listen to things, or just watch a minute and a half reels or shorts or TikToks. There used to be things called message boards, and they would be like centered around one topic, and then there'd be different boards within the board, like maybe manual therapy or strength training or bridging the gap or
Mhm.
whatever, all these fancy things. So some of the people started saying like, hey, you know what? Like I think we got to Erson, and I think he actually is changing. People are like, no, he's still an idiot. And I'm like, man, like I actually am on your side now. Just that when I present pretty much the same information that you were presenting to me a long time ago, I don't do it in a way that makes you feel threatened.
Yeah. Which gets into, I mean, you've been an educator for a long time, not just in, a digital platform. That's a lesson learned, right? Whether you knew it before then or not, is the way that you approach a topic can matter, even if you have the same information. Is there anything that advice that you give to people that are wanting to get into education or social media, if we want to, depending on what you're delivering, call that education, of, having not just an open-minded approach, but hey, why don't you think about these, one or two things before you start teaching your own ideas or other people's ideas?
Yeah, I mean, I guess the first thing would be is to be open-minded. I mean, one of my colleagues who refers me a lot of TMJ patients says that a red flag for him is someone who is 100% certain
Oh, yeah.
why something is happening.
Yeah.
That 100% certainty. Another one of my friends said is that only Sith deal in absolutes, right? Like, like
What's an impossibility?
like
right?
a Sith Lord, right? Absolutely, yeah. Like if you're 100% certain about anything, as I was earlier in my career, that I was like I was destined to be the next big thing.
Yeah.
Like I thought that my goal was I'm going to take as many courses from as many gurus as possible, and when they die, I'm going to replace them. Like I'm going to replace all of them.
But I think that's a shared sentiment across Kairos PTs. You get out of school, and I call this the pyramid, or the path of competent confusion, right? You get out of school and you literally, I thought I was going to work with like my mom's cardiac case and this. I was like, dude, I know physiology. Like I can do all this stuff. And then you slowly start to lose confidence as you don't have the results when you get into private practice that you thought you'd have. You're like, oh, wait a minute, this isn't working. Then you start taking more courses and you're like, I know what's going on. And then you realize everybody at the top doesn't know what the hell's going on, because nothing is law, nothing is fact, especially in our world of human biology and physiology. And you're like, you're just kind of okay with kind of not knowing and keep asking questions and trying to figure it out, and, having hopefully success with patients and good outcomes and not hurting people. I mean, that's ultimately the goal for the most part, is maybe as bad as that is to say.
I know no one wants to hear like, man, that guy's my doctor and he doesn't know what's going on.
But I say the same. I literally said that 2 days ago to a patient that, they had been to an ortho and, an emphatic diagnosis based on imaging and all these things. And I go, we just tell people to run for the hills when people are completely certain and there's no other option, because that will lead usually to bad things, poor outcomes or whatever. So yeah, I echo that all the time. If you don't mind, let's back up because we kind of jumped in, which I love.
I know. I was like, oh, this is recording already.
Yeah.
And there's not even an intro.
I do that all the time, which for people listening, Erson was like, hey, do you want to do a meet and greet? And I was like, I don't, because every time I do it, I wish I would have recorded
I'm good with that.
And
I'm good with that. There are so many times, even on my podcast, especially when I did like an amazing interview or someone like Stu McGill or someone like that, then we hit stop. For me, it was always the stop. It was like we hit stop and we talked for another 45 minutes. And I'm like, oh man, I wish, like, why did we hit stop?
I've done that numerous times.
I totally get that.
A rookie, and I was like, and then it would be with people that I'm too kind of starstruck to be like, hey, whoa, let's back up. I just keep going. So yeah. But when I was reading through some of your bios, which I'll get to the plethora of websites that you're attached to and all the business endeavors, but I kind of read in there that both of your parents are physicians. So first, I wanted to know. So I wanted to know, besides the mental trauma that maybe comes along with that, what type of physicians, and then what did that foster in terms of how you were brought up and mindset, and then you entering, PT school? Like, what did that look like from, early on until kind of now? How has that affected you?
Yeah. You're a chiro, by the way, right?
Yes.
Okay. Yeah. Okay. That's what I thought. One of the good guy chiros, I assume. That's what I call the rehab-based chiros. Not. This isn't a straight chiropractic podcast, right? We're not going to talk about like about VSCs and stuff like that. Well, I mean, I always was. I guess to back way up, I never had this fear of medicine or of doctors or of shots or anything. Like I never understood why my friends were afraid to go to the doctor. I mean, even my mom's a pediatrician, my dad's a cardiologist. So when I was growing up, basically I thought the way I understood it is my mom saw kids, my dad saw old people.
Yeah.
So everyone in our small town of like 36,000 people, Jeanette, Pennsylvania, outside of Pittsburgh, everyone knew my parents, which irritated me in a little bit because like literally everyone's parents saw my dad, and everyone brought all their kids to my mom, and everyone loved my mom. I mean, even my mom had like bumper stickers that I love Dr. Eloisa. She was also a Dr. E.
There was a little marketing influence early on too, huh?
Yeah. Yes. And then also, I thought I think I want to get into medicine for purely probably like greed reasons. I saw my parents were probably well-to-do, and everyone kind of knows that traditional doctors make money. So I thought I'm going to do that. But schooling seems kind of long, so I decided to become a physical therapist. And at the time when I graduated high school in 1993, a long time ago, there was only like master's programs are just new. So I entered one of the first dual BS MS programs, and upon graduating, I found like one of my ortho professor he was a fellow of the American Academy of Orthopedic Manual Physical Therapists. So way back then, most bachelor's programs of the orthopedics, they had 3 credits, 1 semester of orthopedics. We actually had 5 credits of spine and 5 credits of extremities, and much of it was manual therapy based because he was a manual therapy fellow. So we learned a lot, like as much as you would learn in a basic manual therapy residency. And that kind of like sparked I thought back then, like manual therapy was just like the next big thing. There's like always the next big thing. It's going to be like the next 5 to 7 years, people are going to be obsessed with it. And it's going to like, if you learn this, then you can throw everything else out because you're going to be able to fix everyone. So manual therapy was just kind of burgeoning. And I thought, I'm going to be a chiropractor. Right around when I'm graduating, I told my parents, I think I want to become a chiropractor. And they're like, well, we've helped you with your school or you haven't had any loans because of us and everything, but we're going to disown you pretty much if you become a chiropractor. Because at the time, a long time ago, even especially old school MDs did not, they probably remember like the Commission on Quackery and all that stuff, that like how there was like a witch hunt for chiros that the AMA did. They probably remembered that. So they're like, okay, chiro's kind of out the door. And then one of my preceptors or clinical instructors basically said, hey, have you ever heard of Stanley Paris? And I said, who's that? And it was like this guy who always advertised like one of the founding fathers of the American Academy of Orthopedic Manual Physical Therapists. He just started his own residency in DPT programs, one of the first doctorate programs in the United States. I graduated in the summer of May 1998. 2 days later, I enrolled in this program and I started the program. Like I had 2 days off and I started this doctorate residency program. And I asked my mentor, can you can you be my mentor? So I worked with him for a year. I flew down to St. Augustine like every month. I took all their courses, got certified, failed the first time, went back and passed because I just wasn't ready. I didn't have enough experience. I had all these techniques in my head, but had minimal experience. And you needed experience to be able to pass the manual therapy certification exam. So I finally got a doctorate in like 2 or 3 years after I graduated. My parents finally stopped bugging me because like they would call me like every week, hey, you sure you don't want to go back to med school? We'll pay for it. You sure you don't want to go back to med school? Finally, when I got a doctorate, they kind of thought like, oh, well, that's almost like you're like a real doctor, you know? So they stopped bugging me, and that was that in terms of, you know, how I got to be a DPT. One of the first DPTs probably in New York, I think.
So that was early 2000s when you graduated from that program, or
2000.
2000?
1999, actually. Yeah, 1999, I finished my program. 2000, I think I may have been awarded like it was 99, I think I graduated. In 2000, I think I finished my residency. And then I got my fellowship in 2004. And along with like all the other stuff, the McKenzie certificate and all the Mulligan courses and whatever. Then I went on this mission of, that's when I went on the mission of, I'm going to learn from every guru. And I tried to get it certified in as many different approaches as possible.
Which that leads to...
Then it all got...
That's one of my
got jumbled in my head.
Yeah, well, that's one of my questions. So obviously we all have an evolution through, you know, practice, you know, both as a professional person, but I'm sure you were taking a ton of courses, but what were some of the bigger influences from outside seminars, outside of the DPT program that you're like, hey, I leaned very heavily? Because that's like the bygone era of ART, right? That's when it was starting to explode. Was there anything that you're like, man, I'm all in on this. That's what I'm going after. And, you know, maybe we can go in 5-year increments up till now of like kind of what you've leaned on or, you know, looked at more so as you went through your career.
It's funny. I planned on doing like these kind of parody videos based upon overconfident clinician every 5 years, right? Every 5 years, I would say like when I first graduated, I'd be like, I have 5 words for you. I can fix your back, right? Or in 5 years, like I have 5 words for you: transversus, abdominis, contraction, exercise, program. And then I have 5 words for you: functional, exercise, triplanar, movement, program. Then I have 5 words for you: instrument assisted soft tissue manipulation. Then I have 5 words for you: pain therapeutic neuroscience / pain science education. Then I have 5 words for you: nutrition / breathing / kettlebells and movement / strength training.
Which
then I have 5
words. We'll come back to this because I want to know what you were in. But this brings up an interesting point about our profession, right? And the way it... If you have not checked out anthroedu.com yet, I highly encourage you to. If you're looking for the best in continuing education for chiropractic, physical therapy, athletic training, strength and conditioning, this is the place to go. I host a residency where we have a mentorship program where that's both free, which we have lectures, a whole compendium of videos and research reviews behind the membership wall there that, again, is free. Also, this is where I host online courses like my Rethinking Running Rehab course, which there's a whole 12-hour online course there that you can take now. And it's also the place to go for updates on future live courses, such as my Art of Assessment course or the RX3 course. So again, head over to anthroedu.com to learn more. Let's go back to you specifically. So you kind of gave us the 5 words. Early, I'm assuming because you were heavily influenced by manual therapy and, you know, your physical therapy program. How different was practice back then for you versus today? Or have you actually come back to some things just with a different frame around them? Like, how's that kind of work? Because for me, I'll just kind of preface it is when I'm working with students or teaching or talking to anybody, I always kind of say like, you're just running all of these seminars and people's ideas through the filter of basic science. If it doesn't uphold to basic science, it doesn't jive, right? It may have anecdotal outcomes, but also, you know, your personality, the clothes you wear, the color of the wall, those have outcome effects. So like, what were some of the things you're like, holy shit, this is like, you know, blowing my skirt up and this is the best thing. And then slowly you're like, I just don't know if this is even something I want to do anymore. Like, was there anything that like you've kind of waxed and waned, completely got rid of, or something that's stuck would be maybe the more important thing to talk about?
I mean, I would say all of those things were things I leaned into heavily because like anytime you invest into a seminar, you immediately you see the instructor who's like just some typically a charismatic guru type person have like an amazing rapid effect, amazing rapid transient effect on something. You're like, whoa, that was amazing. It was so easy. He made it look so effortless. Then you go back and typically, I mean, I guess this is also something I say in my seminars. It's almost proof that manual therapy is non-specific effects because everyone says you have to do it exactly one specific way, and you go back and you totally bastardize it and you still get great results that apparently were better than the Friday when you left.
Yep.
So yeah, I mean, I would say I initially was very attracted to spinal manipulation, and even when I still do spinal manipulation, like if I do 2 a month, that's a lot.
Yeah.
Other than the fact that if I'm teaching that month, maybe I'll do more.
Mm-hmm.
You know, and do I still like to do it? Yeah. Do I still get the same high during a cavitation that a patient does? Yeah, because it's like something I always tell people when I'm teaching. It's like it's the only thing. Like you never see someone do like a neurodynamic stretch, or you never see someone do like a first rib mobilization oscillation, and give like high fives.
Yeah.
But there's something about when someone first gets their cavitation, they're just like
Oh, yeah.
like it turns men into apes, you know, like women are screeching and gasping, and it's just like it's primal, right? There's something primal about it. So do I still like it? Yeah, I do. And I'm basically only do it if the patient really wants it. But even if they want it, I give them that because there's research that basically shows that people are more likely to respond to it if they have positive experience with it in the past. But then I tell them, hey, look, I'm cash based, right? So if you want to keep on paying me to do this, I'll do this. I'll take your money. But if you actually just this is a temporary window of improvement, right? So if you just do these movements that I prescribe to you regularly that have the same effect, you won't need me or anyone else. And that's kind of like that was a transition. A lot of the stuff that I use and that I used to use heavily, like whether it's ISTM, manipulation, neurodynamic techniques, any of these kind of like manual or pin and stretch type techniques, which I also kind of made pain free. My whole approach now is a completely pain free, even though again I used to just like bruise people all the time. If you look at the first year of my blog, there's like pictures of me bruising people's IT bands, and now I say like even though I still use my tool because I still want to sell tools, I say you use them with the force of a happy cat or dog licking you.
Yeah.
Because all they are just it's just stimulating the skin and mechanoreceptors, and that resets something in the brain. So I still use a lot of those techniques, and that's why I put the modern in front of modern manual therapy. Like all these old techniques work, but it's in the way that you present them, right? Because I think like the trend in the past 5 or 6 years of new grads coming out of I don't know if rehab-based chiro schools are the same, but PTs are basically like strength training is the only thing you should be doing. Like strength training is the only thing now, right? Like forget about it. Like I don't know. Apparently, when someone has a lumbar lateral shift and they have neuroscience, and if they forward bend one more time, they're going to lose bottom bladder control. Apparently, they still give them kettlebells to swing around.
We've seen
like
do that.
I'm sure, and maybe sometimes it works. I've actually had it work when nothing else worked, but I always say like manual therapy is a cheat code. Like my modern definition, like manual therapy is like a video game cheat code that gets people to do their active strategies as pain free as possible.
Yeah.
Because people talk about like, oh, it takes like 4 to 6 months for I saw like there's these people called, I think they're called like the strength physios or something. They're all over social media. I think they're based in Greece. They tag me every once in a while because I think they appreciate my approach, and they're like, oh, look at this evidence. It says like a deadlifting program in 6 months the chronic low back pain is better. I'm like, who wants to wait 6 months, and who can say that in 6 months it was purely a result of the program? Because it's like regression to the mean. That's purely the definition of that. So I don't know, like no one wants to wait 6 months. Like if you can get someone better as fast as possible and empower them, like I don't care what your treatment is one of my favorite quotes. I only care what did you teach the patient?
Yeah.
Right. And how did you present the technique you did on them? Did you present it as a fix, or did you present it as a temporary desensitization of your nervous system, so that now you're able to kind of capitalize on active strategies and movements and positions that were previously sensitized?
Well, we are just beating people over the head with the fact that, we know for a fact, I mean, people just know it because you limp, but evidence would show like pain modulates movement. So if I'm having a hard time doing a movement oriented task because of pain and I can modulate, change, reduce pain, yeah, why wouldn't you? And aren't you beholden to it if you are able to do that, based on the skills that you have? The other interesting thing, which I 100% agree in our world, there's two things with new grads. It's grab as many tools as you can, but then you have no clue how to apply or integrate any of them, which actually I think like creates a problem. It creates a bit of a bottleneck. And then it's lean on. So then it almost becomes, I have all of these tools within our realm, neurodynamics, DNS, all these things. But then you see people lean heavily on strength and conditioning principles because I think they don't know what else to do. And they think, well, I'll just create a more robust human in the face of possible pathology, pathway anatomical, something going on. But it's almost to me like we've went back, like bell bottoms came back in style. It's like 1970s. It's like we're back to doing like, quad sets and just strengthening weak muscles. It's like, whoa. Like we went through this whole progression of, maybe too heavy into manual therapy. Then it kind of backed off pain neuroscience. Now it's back to, well, hey, if you're not load managing somebody from day one, like you're doing a disservice. And I'm like, again, everything is just cyclical, but it's all the same stuff. And maybe there's new levels of evidence which help or hurt. I don't know. That being said, I think one of the remedies, right, for new grads, new docs that have all these tools, maybe you're kind of walking a path that they're like, I just lean on stuff when nothing else works or I don't know, because they need mentors, right? They need somebody, whether they're working with them professionally or that, they're a colleague that they talk to. So going through practice, did you have any mentors that you really leaned on that you either worked with or, were ahead of you in practice or even maybe outside of the field that really helped you through your career?
Well, one of the things I lean most heavily on are McKenzie principles,
Mhm.
because basically anytime you modulate pain, like I'll say like ISTM, manipulation, neurodynamics, corrective exercises, DNS, anything that gives a rapid change where you have that neurophysiologic reset, they're all neurophysiologic, right? So they all
Mhm.
have the same mechanisms, even if like they're commercial based models tell you they have different mechanisms, they really don't. So the one thing that I appreciated most about Robin McKenzie's work is that even if like most of his theories as to why it worked, like disc reduction and things like that, jelly donut theory, they've been disproven. I remember even when I was getting certified in 2004, they all said, "Look, we're moving away from the jelly donut theory."
Mhm.
But the one thing we know, and we actually have research to back up, is that the repeated motions work to modulate pain.
Mhm.
They work to improve function. They work to centralize pain. They reduce lateral shifts. They work very well on spine. We're starting to experiment them with extremities. So even if even if all our theories are wrong, we know that the techniques themselves work, and that's a pretty open
Yeah.
thing, because I've never heard anyone else say that about their own approach. Like you don't hear ART saying like, well, these techniques work and we don't really know why they work.
Yeah.
They just say this is why they work.
Yeah, it's almost
right?
like some people lean too heavily into the mechanism when everybody that's listening is kind of like, we don't know if that's true. And which kind of gives you a little bit of like, for me, gives me a little bit of withdrawal, right? Like, what? I don't want to go heavy into that. Whereas McKenzie, having that open book, hey, we're looking for what's going on. I mean, that's what we're all hopefully doing, right? It's kind of like we said,
Yeah.
confident confusion. Like, I don't know why, but it does work. Let's explore. Yeah.
Right. So those principles basically enable me to empower patients with enriched loading strategies, and then I get into the strengthening. So I get around to the strengthening, but I think
Mhm.
we're most of like the bridging the gap type. Like I'm a strength coach and a PT, or I'm a strength coach and a chiro. I think that where they go wrong is they don't modulate the pain at all, and they're like, well, research shows that it's okay to load a tendinopathy even if it's painful. I'm like, yeah, but they have to want to load. Like someone has to be really trusting that they're not going to rupture their Achilles if it hurts like
Yeah.
a 7 out of 10. You're like, it's fine if it hurts a 7 out of 10. You're not going to rupture it. Well, maybe they won't, maybe they will, because people like bend over and it ruptures. You know what I mean? Like sometimes it's just a straw that breaks the camel's back, and they have to be really confident in the program. Like maybe if you just wrap them with a mobility band,
Yeah.
or if you do a little scraping, or you do a little mobilization, you modulate the pain, where you manipulate their lumbar spine at the segment that like will affect the ankle, and you modulate the pain, and now like, hey, that 7 is now like a 2. Yeah, well, maybe now they're way more likely to load their calf.
Mhm.
That's why I say manual therapy is a cheat code to get people to do the program, because the program is what makes people better. It's not you.
Right.
So I'm totally on board with that. But how do these people get, when you load too early, how do they get them to, because it's all about dosage. I love the saying, it's been around forever, movement is medicine. Yeah, movement is medicine, but you know what physicians do better than like rehab gurus like us? They actually do they prescribe a dosage, right? The dosage they realize is what matters, and we can't just tell people to like, hey, you need to do the strength training at this particular dosage, and then the patient doesn't really understand that they have to do it, right? The dose, like they can't just say like, even if I just gave someone chin tucks and it, I demonstrated that like, look, you just did like 20 of these, and your headache and neck pain is completely gone, and you have to do them 10 times an hour. I just like, and they're like, what's 10 times an hour mean? I'm like, it means 10 times an hour, but it also means it enough to stay ahead of it. So you can come back, if you come back next time, you're like, I'm not any better. I'm like, how many times you do? Oh, I did like 3 over the next 2 days. Well, you didn't follow the dosage, right? People understand. And I just say like the dosage for this is just like the dosage for medication. You just can't say like, I still have this infection, but I only took my antibiotics like once, and when I was supposed to take them like 3 times a day for a week. So I don't even know where I got it. Everything about me is like a train that is waiting to derail.
I can parallel that thought process for sure. Right. Well, one thing that you brought up in there that I just did a podcast a couple weeks ago with Dr. Phil Snell. Phil, his whole kind of train has diverted.
He's very McKenzie based too.
McKenzie, and now, leaning heavily on new research, which a lot of the research comes out of anesthesiology on, this peripheral neurology, which is a lot of, what Capo's worked on with rock tape, but looking at the changes, the cascade that happens kind of in what we would call a retrograde fashion from peripheral sensitization, which is interesting when you talk about modulate pain or not modulating pain, then going straight into load management. Phil was just bringing up that there's more and more evidence coming out of like, hey, a cutaneous nerve can get irritated, and that actually is creating a trigger point, which then creates, altered arthrokinematics. And now you have more central sensitization based off this peripheral thing, maybe not a central component where we think, chronicity of tissue, maybe subthreshold damage is causing it. And he's like, it might not be. It might be that it's a little bit pissed off and it just starts winding up this, the signal. So again, my thing is that I can't comprehend is that you go to school for, 4 years ish to learn all these tools. And like you said, you'd be willing to trade it in for a CSCS and say, hey, let's go this route. There's a time.
Right. I know. It's like, why did you even go to school to be like a DPT or a DC, right? If all you're going to do is be a strength coach. And I'll say, like, look, I get it. Strength training, I love strength training. Even in my courses, strength training is probably not just exercise, but strength training is probably the only evidence-based treatment that's good for every condition. But they have to be able to do it.
Yeah.
And they have to be willing to do it. And most people who are in pain are not willing to do it. They weren't even doing it before they were in pain. And all of a sudden, you're prescribing them a strengthening program, and you think that like they're just going to do it because they're in pain?
Well, here's a question for you. So this is something that kind of, it just comes into my mind when you look at the swath of information on Instagram or whatever of people that are leaning heavily on the, hey, movement first, load management. Let's move away from, the tyranny of the table or the, whatever we're going to call it. What's that mean for the opposite side of the spectrum of somebody that's an elite athlete that is absolutely being load managed, down to the nth degree, and now is dealing with pain? Like, well, can't we backwards extrapolate that to, the layperson? Whereas we're just saying, well, this person is being trained at a super high level. Not saying you remove the possibility for mismanaged, strength training, but it's a very different animal. And then to say, well, no, we just need this. I get that we have an unhealthy, population in the US. So I get that. Most people don't move, they don't exercise, they probably are mismanaged from a load standpoint. But it just always kind of makes me wonder, like, yeah, but if you get that elite athlete that walks in, there's no way you're going to be like, oh, your Achilles hurts, let's go. Like, they got to your office for a reason, just like somebody else did. Now the reasons may differ, but it leads into, which props up our next question, like proper exam. I saw you at a podcast of, you were kind of poking fun at yourself of like, something like PT shouldn't diagnose because I think there was a pelvic fracture or something. You were just kind of making fun of yourself of like, dude, the person literally got better. They had less pain because we were doing things that can work well, right? We're great at reducing pain, but you're like,
well, I mean, there were a couple of those things where I missed. Yeah, like I gave someone unilateral kettlebell carries because they fell off a bike and they were like diagnosed with hip bursitis. And I always tell people, like, I very rarely see a true hip bursitis. Right. Like, when do you ever really see a hip bursa that's like big, red, and inflamed? The doctor acts like it's like a huge red ball sticking out of their hip. And I'm like, I haven't even seen that. I actually saw like a biker who said he had hip bursitis, and his wife was rolling out his leg, and it was in the winter, and he's like, oh, the roll massage stick is so painful. I told him to roll up his leg. He still had rocks in his leg. They're stuck into his skin. I'm like, well, that's probably why it hurts so much. That guy didn't even have bursitis, but yeah, oh wait, sorry, what was your question?
Yeah, we were going down the road of like proper examination, saying how, if you're going to lean into load management, well, how did you get there? Versus, hey, I need to desensitize. Hey, I need to refer out for imaging or refer to another provider.
Right.
So
right. Well, first I'll try to modulate the pain. Right. If I can modulate the pain and then get them doing active resets to self-modulate the pain, and they can. This is a very McKenzie-like rule. It's like, well, you can start to return to function within being 48 hours of. I used to say completely pain-free, but now I realized that was like a very arrogant thing, and I'm like, when you're 80 to 90% better, and you can start exercising up to a 4 out of 10. So I use like this elite athlete research. It shows that elite athletes who exercise returning the injury above 4 out of 10 tended to prolong the injury. So I just use a blanket 4 out of 10 for everyone, because I realized that there are some people who just need to start moving sooner.
Yeah.
And they may not get to be 100% pain-free. Like, it is actually okay to discharge someone who's not 100% pain-free, because that's also like an error I made a long, long time ago. You just keep on seeing them, diminishing returns, like 30 visits, 40, 50 visits either. You're still like 1 out of 10. You're like, man, when's that 0 going to come? They're like still paying you, so yeah. I start with repeated loading. I get them to be able to desensitize, also avoiding the things that sensitize their system. Like, I think that people who leave and they're better, regardless of whatever you do, a lot of clinicians don't manage the things that fill up your cup, or they don't tell the patients to temporarily avoid the things that fill up your cup. Like, maybe they're deadlifting and they're gardening, or maybe they're deadlifting and then they have a sitting job. So it's not like they can't sit, but I just say, because I don't correct posture anymore, no static positions of greater than 20 minutes, 2 outdoor walks a day, get 8 hours of sleep. Those are my generic things I add to every recovery plan. And I call them all recovery plans, not homework, because no one wants to do homework, right? But when you say recovery plan, you can steal that, by the way, anyone who's listening, people actually want to do it, but no one wants to do homework, because the connotation behind homework is like, oh, I have to do this because it's good for me.
Yeah.
So then eventually I get around to strengthening, and that's what I'd use, like the building the bigger cup. And I think people all automatically assume you build up the bigger cup, you build up their capacity, they're going to be able to do more things. But sometimes you don't have to build up. The assumption is that they always have a smaller cup to begin with, and that certainly may be true. But like you said, if you are working with an elite athlete, they don't have their cup is already like bigger than yours will ever be. And a lot of times you just have to look at other things, like what are they doing that fills it up, or even is their fear avoidance so high that they're waking up every day with a cup that's like super, super high. Like the last professional athlete I worked with, he was so afraid, even though he could do all these amazing things. He's an NHL player. He was afraid of having pain with extension. So luckily I was able to do like a 3-hour exam on him, because he was my only patient, because they flew me in to treat him. But I just did this after, doing lots of education, checking out his movement, and assessing all the other things I'm going to assess. Like, the most simple, powerful thing I did for him was just have him extend and standing, and then I just resisted extension. Because isometrics is such a powerful pain modulator, and at end range extension, it hurt like 5 out of 10. But with resistance, 0 out of 10. And I'm like, push, like activate those extensors as much as you can. Because his PT was like, well, he's already doing a posterior chain stuff, strengthening. I'm like, yeah, all leg posterior chain, not upper back posterior chain. So I started like 3 years ago, I started kind of getting into like some of these chronic lumbar cases. I went back and I'm like, there's got to be something about extension, isometric extension strength. I think my podcast host said, like, yeah, there's some research on that. So I started looking it up, and like, oh yeah, there's like research from 2013. People stopped looking at it, but I'm like, there's something to that, about like something about extension strength. But anyway, after that, his eyes were open. He's like, like, it doesn't hurt. And I'm like, yeah, look, you're in like as much of a lordosis, your end range extension, and I'm actually having you activate your erectors. If compression was a bad thing, like he flew all around the country, everyone was telling him like, his spine was so bad, his scans were bad or whatever. And I'm like, if all these doctors were right, I'm having you actually activate your extensors in an extended position. So if compression was bad for you, it would actually make this hurt worse, but actually it makes it feel better. So then, like, that was like this big kind of like aha moment that you don't get all the time. You take like a pain science course, you act like you're going to be able to talk everyone's pain, like you're going to make everyone have that light bulb, right? But I mean, this happens like once every 5 years where you get like this one of these huge breakthroughs. But I mean, he hadn't been playing for like 6 months, and then he was able to finish the season finally after like I got him not afraid.
Yeah. Which I think that's a huge point, because talk about the layers in there, right? There's a pain neuroscience component of, the conversation and education, but there's also I would say kind of you're looking at quality of movement, because you're like, hey, I get that you extend, maybe your end range extension isn't amazing. And then your ability to kind of modulate force production at end range could be, dependent on the pain that you've dealt with, whatever it is. So there's all these layers of, exactly what, you call the eclectic approach now is like, you're not just like, hey, we do a McKenzie. Oh, we went through McKenzie, still have pain. Like, okay, what's that next level based on something I read? And you're just adding in layers. So where at some point in anyone's career, it could happen earlier for some people, later for others, everybody has to start with a system, whether that's the examination and treatment protocols you were taught in school, early mentors, systems like McKenzie. If you go to a purely McKenzie clinic, it's very systematic, and it's assembly line-esque. Where do you think
it is? That's why they call it a method. Yeah.
Which is great.
Yeah.
But then the method has to be broken, because there's going to be things where people fall outside the line. So where
people fall out of it.
How do you, what advice do you give to clinicians, students on, when intuition can kick in, or how to build that process of trusting your findings that go outside the lines of a system that you've adhered to or learned? Because I think that's the hardest thing to do, is trust yourself at some point. So any advice on that?
Right. Yeah, well, I know the imposter syndrome is real. I had never heard of that. That's probably newer than I'm on the tail end of my career, doing this 26 years. I had whatever the opposite of imposter syndrome is. I had superhero syndrome. I just thought I was the best thing ever. I never thought I was wrong and I knew everything. But in general, I just say you need to know your limit. When my limit is about 2 to 4 visits. And I say that I get people either 80% better in 2 to 4 visits, or I don't, but I don't keep on seeing them. And that's assuming that they're compliant and that things make sense. And they're not maybe centrally sensitized. If they're centrally sensitized, I have an entirely different program, then I realize they may need maintenance. But the majority of people don't need maintenance. They should just be better within a certain period of time. A very simple McKenzie in-house study basically showed it. And there's this stat called the McKenzie 6. All of the McKenzie instructors and the McKenzie diplomats, basically on average, you get people better in 6 visits. So when they look back at all of their their outcomes over, I don't know how, maybe they looked at 5 or 6 years or something. What they concluded was that if they didn't get people better within 6 visits, the conclusion was that they weren't going to be an impossible patient, but they were going to be a very difficult patient. So that you should just refer out, because it's a question I like to ask at every single one of my courses, because there's people who've been practicing for 40 years, people who've been practicing for 2 years, and there's always a bell curve of experience at my seminars. And I just say look, when was the last time someone had 0 improvement in strength, function, pain, anything kind of objective or semi-objective for a month? And when's the last time you were able to have a breakthrough at visit 8?
Yeah.
And barely anyone raises their hand, because it's what are you waiting for? You waiting to throw out this amazing, magic trick treatment at visit 8?
Yeah.
So that's really gonna wow them, So even if your gut isn't telling you something is wrong, it is unlikely that you're gonna get someone better. The only time that someone actually got better, in many times, there's a couple cases in my career where maybe I was trying on and off with someone, and then they finally got better. It was you assume that it's something that you did, but if you were really changing up something a lot, it was always something oh, I broke up with my boyfriend, or I got a different job, or someone who didn't even really seem totally stressed out. They had some sort of major life event, and that was actually filling up their cup, probably due to stress or whatever, right? So I just say you just got to know your limit. You refer out, because I've had patients, I think we're afraid to refer out, especially as novice clinicians. We're afraid to refer out because you think that means I don't know what I'm doing. But I've had patients who refer me a lot of patients because I got to someone who could help them. And they're still happy because I was they wouldn't have gotten to where they were, whether it was a surgery or getting a scan or finding out they have cancer or a tumor or something, that some disease process that needs to be treated. They eventually got the help they needed, and they were still very happy that I made that referral.
Well, one of my mentors, Brett Winchester, always says, in particular, he practices in a small town in Missouri. We're on the kind of outskirts of Birmingham, Alabama. The current medical system, you don't have many quarterbacks for people, right? So like primary care physicians are so busy, they don't have the ability to look. I'm not blaming anybody. A lot of them, unless you're concierge care, you don't have the ability to look at all of the variables and be like, man, we actually need to get this person over here. So the hyper specialization creates silos where literally people can't see what's going on, like with the whole scenario. We are kind of uniquely set up for that because we're asking the questions about lifestyle factors, job loss. We have maybe more time with them than other practitioners. So I 100% agree with you that a lot of your like biggest successes will be how you triage that person, maybe rather than what you did for them in your clinic. The other part of that is that I would agree that maybe we're afraid to refer early on because we see it as kind of a tarnish on our record or something. But also with the new wave of, at least chiros and PTs that we kind of work with, we're seeing a lot of people that, they know the evidence that says 4 to 6 visits is a trial of care. And that's going to be the best, evidence prior to imaging to show like, outcomes. But it's almost like they think they're so good that in like a visit or two, they're like, dude, MRI. And it's like, whoa. Like, you haven't given quite enough time. I agree if stuff's not changing, but also you're going to pick stuff up where, you're going to send out for imaging or refer for a neurosurgery consult early on. But I also see a lot of times that are like, oh, I'm just going to go ahead and send out. And you're like, dude, like, have they progressed? Yeah. So I think sometimes, you have to see the zero progression. Okay, this is not going well, but hey, are you actually auditing yourself? Is function changing in the face? Maybe pain not changing because the boyfriend just broke up with them, right? Or they're going through turmoil. So I think it can kind of work both ways, which gets back to your point of like, know your limits. Like, are you able to pay attention to all those variables? I think that's a hard thing to do early in your career, is to look at the musculoskeletal system, look at all the, diet, sleep, emotional complex, and put all those variables together in a recovery plan, whatever you want to call it. That's tough. That's very, very tough. We're really good at, rubbing tissues and, adjusting joints and using kettlebells, but the other stuff can be, wildly impossible to integrate in early. So besides grabbing all these techniques early in your career and, trying to learn as much as you can over the past, 2+ decades, from what I've seen from the outside looking in, just typing in your name, like 15 different websites come up that you're affiliated with or associated with. So it seems like you've spent a ton of time in continuing education, both taking and teaching, obviously also treating. Diving a little bit into the business side, well, first of all, just give me a quick rundown on all the things you're currently involved in. And then I want to ask a couple questions on like, how do you keep up with all this? How do you build teams to manage all this stuff? Like, what are you involved with right now currently?
Well, I'm a sole proprietor. I've always done everything myself. Anyone To start, I have a cash-based clinic at Rehab in Sports Science in Buffalo. I see patients like a handful a week because it's not my primary business, but I never wanted to be one of those instructors that says like 20 years ago when I was seeing patients, this is what I did, and I think you should do it too, based on the evidence. I still want to see current cases, and I still know that I could help people that maybe could not get help with standard care. So I have also my e-commerce store, which sells like PT products. All my online seminars are on there. Rehab-based products, I kind of vet. I see things that are expensive, and I try to come up with my own, like either white-labeled version or, like a cheaper like version, whether it's for the public or for clinicians. So it's kind of like a B2B and B2C model. I also just mentor clinicians online and sometimes in person, but mostly online. Like if they're manual therapy fellows, or if we have like a 4-month mastery program that kind of encompasses all our courses, because I have like modern strength training, which is BFR. Then I have a modern patient education, which is all the soft skills of like nutrition and pain science and movement and sleep and recovery. We have a nutrition one too. So those are like the 4 courses along with modern manual therapy that take up like our 4 to 6 month online mentoring program. But yeah, I'm affiliated with like all kinds of other things too, just like because I have lots of followers online. So people, see me as like a PT influencer on like the board for Sleep Junkie, which is like some sleep website. And I was part of Active Core for a while, which is like a PT PT out-of-network clinics that use Redcord. I don't know. I'm going to be involved with Kappa's new thing, I guess. Mike Reinhold and I have worked together. I also have a lot of websites that I like. I probably own like 50 domains.
There's a
so
lot.
I don't even know how many of those websites that are actually mine, that just something that I put together, like that are all kind of like fall under my own umbrella.
Yeah.
But I mean, everyone who I've ever hired. I never hired anyone. I've never had any W-2s. Everyone who I work with is always like a 1099, Even on my websites, I try to do them all myself, all the video editing and everything.
Well, that's my question. So I'm in the same boat. So now kind of getting self-help therapy here. I've been in practice going, a little over 10 years now, started our own clinic. My wife and I, started building our websites, started, a YouTube channel early, started playing in podcasting when podcasting was new. All this stuff for a long time, and a lot of advice from outside of our field and within says you need to do everything you can to offload as many of those tasks as you can, right? Like work on the thing that, skill stack. So we're, clinicians, we're educators. That's what we should be building skills on. Maybe not editing videos, right? Maybe not podcasting, maybe because it, kind of helps sharpen, steel versus steel sometimes, I believe. But are there like continued repeat sources that you go to for, video editing or anything? Or is it literally you're like, dude, I'm doing all this on my own. I'm editing podcasts. I'm editing all those shows. Cause I'm not saying that can't be done, because I've done it and I've had a hard time offloading for various reasons, right? Creative input. It's actually easier, faster, cheaper for me to do it sometimes. So I'm like, why would I pay somebody? Like, what's been your experience of that?
That's why I do it. One, because before I did any of this, I thought I've always loved tech. I've always loved computers. I'm an avid gamer. I put together my first computer when I was in grade school. If I didn't do rehab, I would have done something in tech.
Yeah.
So I love technology. For me, all this stuff is fun. So I can do it very fast, very efficiently. Yeah. Plus, I've seen people like some of my best colleagues, buddies, rehab, but I know also in person I've hung out with, like Reinhold and Aaron LeBauer is like a cash-based guru. I've seen them have like amazing VAs, and then all of a sudden their VAs literally drop the ball, and I'm just like, man, what happened? Like you haven't posted in like a week or whatever, or you used to be able to get back to my emails or my customers' inquiries or something if we were like have some joint project, and now like they're like these customers are going unheard, and they're like, oh yeah, my VA just totally dropped the ball. And I've seen it happen so many times. And they're like, oh, by the way, we recommend a VA. But I'm like,
really?
So in order for me to offload all these things, I actually need to train the VA only. And I've had this happen with not a VA, but let's just say I'm on maybe the 6th or 7th manufacturer of a simple edge tool. It's just a simple steel tool. It doesn't have any moving parts. And I have like the first 4 manufacturers made like maybe 5,000 great ones. And all of a sudden the quality just like goes down the hole. It's like, man, what happened? So like I think it's like this kind of inevitability that where you're just going to have someone who's so loyal to you that they're going to bring their A game every day. So I don't know, because I can just do it myself and I think it's fun. I think for the majority of people who don't like tech and who don't like know how to code or edit a website quickly or easily, then I think, it's probably in your best interest to hire someone out. Like me, I could do it for you.
I did see that website as well.
Right. Yeah. So, I mean, I can make a clinic website for you in a week.
Yeah.
You fill out a Google Doc. So because the majority of people who you're hiring to do these things, they're not developers. They're just like filling in a template anyway.
Yeah.
So it's like I could do it. I could do it cheaper. I would say that's not a reality for the majority of people. It is my reality. I think it's fun. I have a lot of passive sources of income that give me a little bit more time. Initially, I was hustling and working so hard to the point where, like, when I was blogging and I wasn't like bringing in passive income or wasn't getting a lot of gigs, my wife's like, oh, you need to come to bed. And I was like, no, I just need to answer one more email or whatever. I need to like keep on editing these videos. And, now I have more time. So where do I get the time? I have more time, but I hustled in the beginning to create so much content, to build a bunch of loyal fans who like attend my seminars. I still get people like the 10 seminars that I'm teaching this year. 7 of them are people who read my blog. So it's like, because I had a crazy amount of free reach, like reach was free back then. If I would posted a link to my blog with a picture, I would get 200,000 reach.
Oh, wow.
in like 2014.
Yeah.
It was crazy.
Yeah.
Now if I pay like $200 to boost, I'll get like
600.
500 reach. You know what I mean? Yeah. Like I gotta pay to get like any kind of boost, you know. But I mean, back then, I just built up so much goodwill and everything. I hustled.
Yeah.
I hustled. But what I always tell people, because another like disturbing trend that I've seemed to see is that people are like, they either say like, you gotta have this work-life balance, and they think like they need to like balance all the work with all this fun, or that you just keep on working and working and working and working, and you never ever get the other part. So like these two extremes. So the one I would just say like, well, you have to put the work in, you like pay off all your loans, and then maybe you take your $10,000 vacation.
Yeah.
You know, and then for the other extreme is like some guy came on my old podcast and we're talking about the work-life balance, and then after this, like I was teaching a course and so I was like, oh man, that guy's on your podcast. He teaches like 50 weeks a year, and the only 2 weekends he takes off are his kids' birthdays. You know, I was like, man,
Yeah. That's
like that's nuts. What I'll tell someone like that is, you don't want to be the guy or the girl who's like on their grave says like they were a good provider, but that's it. You know what I mean? Like, you want to be known by your family, like have a goal. And once you reach your goal, you can start to taper off. And that's kind of what I did. Like, do I still hustle and work hard? Yeah, but I made it so that like right now, before this, I was just mowing the lawn, listening to a podcast.
Hey.
And then I'm like, oh, I have this podcast, I got to jump on. And then now I'm going to go swimming with my kids.
Nice.
You know? So,
which by the way, am I correct? Did it say somewhere you have 6 kids?
I have 6 kids. Yeah.
So
my wife's a DPT too. She homeschools. So
okay.
She wouldn't say, she always defers patients and clinical stuff to me.
So for anybody listening, A is in our field, maybe you're not in our field. I love what you just said, not just because it validates some of my own thoughts, which is just, you know, a confirmation bias, I guess, of it is fun for me, right? I like photography. So I've always kind of been in the creative visual. So video came in. I was really good at building websites just because I got in early with some of the templated stuff. And now, I give bad advice. I'm like, oh, you just build your own website. And I'm like, whoa. I can, like, not everybody can, like you said. But for anybody listening, I love what you said about basically building flywheels, right? It's not grind for the next 30 years at the same level. Otherwise, you're not working smart. You know, I live by like, you have to kind of buy back your time, right? And if you're not willing to put in time early, like you're going to be working like that your whole life if you want a certain lifestyle. And you got to be okay with like, you know, being honest with yourself, like, hey, that's not attainable if I'm going to put in this much work. But again, going back to one of my mentors, Brett Winchester, he says, you know, he's a guy that at one point was teaching. I think he had 37 weekends out of the year. He was gone teaching and, you know, run a full-time clinic. And he's like, nobody wants to be married to balanced man. They may say they do, but they don't, right? Anybody that's involved with a significant other, even your kids, they want to see somebody that's passionate about something, motivated, but also self-aware enough to be like, well, yeah, it is important to be with you. I'm doing this for a reason. And like, you know, maybe it's a year or two of like going gung ho. And then all of a sudden you're like, I can pull back or I can be more choosy. But also I don't know about you. What are the ages of your kids? Like, what's the age range?
17 to 5.
Yeah. So I want my kids to see what I'm doing, to see that I like what I'm doing, to see that we're working in a way that we're not just like, oh, I got to go to work. Like, you know, my kids were in the office today. I think that's important because again, now that allows me a little more like maybe validation of like, hey, I can be working hard because I'm involving them. You know, and it's not that I want them to be a chiro or PT necessarily. I just want them to like what they're doing and not just feel like they, you know, dread going to work every day. Well, as we kind of wrap up here, I also saw something in one of your bios that, as you said, you're a huge tech nerd, and I believe that you're kind of a Marvel, maybe Marvel and DC nerd, or is it just Marvel?
Well, it used to be just Marvel. And some of my bios, it says Marvel and Star Wars, but man, like Disney just tarnished that. I mean, so now I changed all of my bios, as many as I could find, because there's a lot online, to classic Marvel and Star Wars. Because I just say like, you know, it kind of ends at like the MCU kind of ends at Endgame and maybe like a couple of movies after that. Yeah. That was like peak.
Yeah.
And then Star Wars kind of like, well, I'm excited that there's 7, 8, and 9. But after like 8 came out, I'm like, oh man, now all my kids are starting to watch Star Wars. I'm like, especially the younger ones, like the older ones, they've watched 7, 8, and 9. Yeah. The younger ones, I'm like, we're just going to stick to like, you know, 4, 5, and 6 and 1, 2, and maybe 3 when you're a little older because like Anakin burns alive. So yeah, I think like there's just peaks to everything, and then like when you start to saturate the market, you just can't expect everywhere. People are like, oh, people getting burned out of superhero movies. Are they getting burned out in superhero movies? Or are they getting burned out of bad stories?
Every
because like
spinoff.
the story,
Yeah.
right? Yeah,
Yeah. Well, my
like
question
there can only
is,
be so much of any good thing.
yeah, and I agree. And I've been a huge fan since I was a kid from comic books. And then actually my wife,
I read comic books too.
yeah,
I read all the I read like all the
all
Marvel
this
comic
was
books,
the
mostly Marvel.
bane of my wife's existence until the COVID kind of great pause. And one day she just comes in and she's like, hey, I've been reading, I don't know, somebody put up a blog of like, hey, you should go through chronological order of all the Marvel movies. And like she said that, and I was like, my God, yeah, I'll do that.
Oh, so see, but that's what I call the stranger effect. The stranger effect is I'm like, hey, I propose to my wife, hey, why don't we watch this movie? She's like, I don't want to watch that movie. And then she's like in the grocery line somewhere, and then she hears like the person in front of her talk to like the cashier, like, hey, this movie is really good. Oh yeah, I just saw this movie. And then she comes home, she's like, hey, can we watch this movie? I heard it's good. I'm like, I just asked you to watch that movie. So now, knowing the stranger effect, I actually, if I want her to watch something that I know she's not going to watch because it's coming from me, I ask my brother I just like, hey, so this is a really good movie, you should like suggest it to Erson. And then she actually, because it's not coming from me, she actually she suggested.
We were FaceTiming with my mom last night, and I put up an Instagram post with a clip from the Phil Snell podcast talking about systemic inflammation affecting pain. And my mom, literally in the middle of talking to our kid, she's like, hey, that was really interesting what that guy was saying. And I was like, I have told you that so many times. And she acted like
maybe I should watch what I'm eating.
Oh, 100. And I was like,
yeah, right.
And I'm literally on the show with the guy, and she's like, no, this guy, he knows what he's talking about. I'm like, okay.
You're on the show, yeah.
So
she only hears, she like fast forwards your part.
Yeah, so I got it in full effect from my own mother last night. So I agree.
Yeah.
But going back to the Marvel universe in particular, you can pull from anywhere. And maybe it's just something of your own accord, because you said maybe you had this superhero syndrome early in your career. If you had to pick one power from the Marvel universe, let's stay there, or somebody's power, if you're, stealing somebody's persona, what are you going with?
And I don't know. I mean, because I'm a rock climber, I always used to say that flying would be like my ultimate power, because then I wouldn't have to top rope. I could just boulder everything. I don't know if you climb, but like, yeah, because like I'm a boulderer, but like when the rope always gets you in the way, you like go too far away from the anchor and the rope's all of a sudden pulling you. You feel like the rope, you could rest on the rope. You can't do that when you're bouldering. And I also used to say, because I used to have a long commute, and I no longer have a long commute. I'm like, well, I could also just fly to work. It would be a very practical superpower, So, but what I think now is, I think maybe I would want, like, even just based upon the stuff that I see, like from the X-Men movies with Quicksilver, like super speed also just looks like it'd be super fun.
Well, they really
like more than anything.
Well, they really changed my perspective. And then if you watch, obviously now we're super nerding out, so people are like, click, turn it off. But yeah, like
I know, right? Yeah,
Flash and time travel, and like, yeah, you're like, oh, I never even thought about all that. But yeah, it's and me being a runner, I'm like, yeah, that's what I want.
Yeah, of course, right? Super speed. Yeah, I know, because you could also run to work faster. I mean, there's just so many other you could do so many other things.
Yeah,
you can be so productive.
Maybe
right?
that's my OCD.
Very practical.
Yeah, I'm
very
like,
practical superpower.
Well, here's the last two questions that I ask every guest, because that was a different one just because I saw it in your bio. So they're both the polar opposites of each other. So the first one is, what is something that you long held as a belief, and we'll take this from a professional standpoint, within your profession, that you're just like, that is not, I don't think that's true at all anymore. So something you're just like, yeah, I just used to believe this is the way it is. And you're like, nope, that's completely changed. Anything stand out?
Yeah, actually, just today, I read a post on LinkedIn that changed my mind. So I've always thought that one-on-one care was the best form of care that you could give. What do you think?
I guess I would have agreed. I don't know. Are you going to change my mind?
I don't know. So people were. This one guy was trolling me. So in a negative way, someone was trolling me like just 5-6 months ago on LinkedIn, about how like, oh, my concierge practice, my cash-based practice, it's ridiculous. The business model is ridiculous. He sees like whatever 4 or 5 patients at once, and his patients prefer it. And I'm like, your patients prefer it? Like, that's like saying that I always say that's like saying like, oh, your patients prefer, like if they go to the barber or the hairstylist, that they prefer that their hairstylist is working, like is cutting 5 people's hair at once. Like I'm like, no one prefers that. He actually, the thing that got him to stop arguing, he was like going on and on. Like he and I just hijacked a thread and everyone just watched, and I'm like arguing with this guy, obviously not convincing him in any kind of way. But I'd never heard that anyone say that they would prefer like a mill type atmosphere, But then someone today was just like a very level-headed, like another kind of PT influencer on LinkedIn, was saying that he realizes one-on-one care is very desirable and a lot of people prefer that. But he said that he is an introvert and he would feel awkward having to talk to someone one-on-one who he didn't know in a small room, which is exactly my atmosphere.
Yeah.
It's a small room inside a gym. You know what I mean? And I was like, man, I'm an introvert. I never looked at it that way.
Yeah.
People don't realize I'm an introvert because I'm like just so animated and everything, and I teach courses of like whatever, so many people. But when like, I don't want to go out to dinner afterward.
Yeah.
You know what I mean? Like,
You
I
gotta
don't
recharge your
mind. I don't mind
battery.
being.
Yeah.
Yeah, for sure. I just want to like go home, like FaceTime my kids, and then like play video games for the next 5 hours and not talk to anyone. Like Uber Eats, like whatever. I like don't even like. I just say like thank you to the guy barely. That's it.
We have a lot of familiarities here, man. So I'm with you. Yeah.
I hear that a lot. Yeah, a lot of clinicians I hear are introverts.
Well, you put yourself out there all day, and then I think you have to kind of retract. My wife is a rare bird.
Yeah.
She gets like energized from the social interaction throughout the day, and she wants to come home and still like talk. And I come home, especially when we're early in practice, and you're just like full. I'd come home and I'd be like, I'm just gonna go sit in a room by myself, and she'd be like, oh, let's go. I'm like, yeah. So I get that.
Yeah, so he was also saying that, there's obviously the older population, and I had this too back when I was a novice clinician, and I would see people like 30, 40, 50 times. Yeah, there's the older population, and they come in and they stay for like 3 hours, and they know everyone, and like there's people there who I call lifers, who I don't have anymore, being cash-based, so they tell the patients who are doing their exercises wrong that they're doing them wrong, because they've just been there for like, whatever, 2 years, 3 times a week. So I get that people have said, oh, yeah, it's not as much of a social atmosphere, the one-on-one. But that was never an argument with me until they brought it to that. Some people may not like it because of that. And I was like, oh, I never thought of it. I was like, thanks for presenting it that way, because the other guy's basically just attacking me, saying that he's a better clinician and he gets better outcomes and his patients prefer it. I'm like, whoa. I don't know. Maybe you're a better clinician. Maybe you get better outcomes, but your patients prefer it. Like, I just couldn't understand that. But he didn't say why. He just blanket 100% statement,
Well, it's kind of interesting you say that. So we moved offices last year, and our previous office, we had treatment rooms because we had 4 docs. Now we have 5. And we've always had an open door policy, just for, doors open unless you're doing something, in an intrusive barrier, somebody's telling you something, and then the door comes back open. And then we had a big open area, right, with the gym area that was in the middle of all the treatment rooms. So I think it kind of made people feel like you could hear other people talking and you're not just in there by yourself. Well, now we're in more of a, the treatment rooms on the periphery. We have, all these things in the middle, and it's a little more cut off, even though it's still open. And I bet I can tell a difference in like interactions with people, right? Like it's a little more like you feel one-on-one, and you can tell people are a little more nervous. So I'm kind of being more aware of this, of like, I'll take them out to the PT bay to do more stuff rather than stay in the room, just for that reason. Like I see them kind of be like, in particular, like say you have a 17-year-old female gymnast and I'm working with them. I mean, that can be just awkward just from the standpoint of like who you're dealing with. So yeah, I would agree. I've never thought about it like that either. I would say if I'm going after the YMCA social effect with my elderly clients, I'd be like, yeah, that's not just my jam. So I'd just be like, yeah, they'd have to go someplace else, which we have a PT that's right by our office that I'd probably send them to. Yeah, I've never thought about that. So I like that.
Yeah.
Well, the flip side is, what is something that you think to be absolutely true that has no evidence behind it, or that a lot of people would disagree with within our kind of our professional setting? Yeah, everybody does
Absolutely.
the same thing. Everybody gives a moment of pause, which I love, which means it's a fairly good question.
Gosh, I don't even know, man. I have to get back to you on this one. I like record it later and edit asynchronously.
This may be the first ever mail-in answer.
The last question. Let me think about this. Wait, absolutely true, but there's no evidence?
Yeah, so you're just like, dude, I think this is what's happening, or I do this with a lot of people, or, whatever it is, somewhat within our profession. They're just like, yeah, there is no evidence, and there's just anecdotal stuff that I've worked with, or, maybe it's even something you just have a hypothesis about that you don't do a lot of in your clinic. You're like, yeah, I think this is actually what's going on here.
Well, I mean, I guess I would just say it's all the stuff I do with manual therapy. I mean, like every single technique I teach, I show a video where I'm wrapping an edge band, not a voodoo floss, it's an edge band, right, around someone's tibia, and I'm rotating the tibia, and now all their knee pain is gone, and people are always like, is there any evidence behind that? I'm like, I always say like, no, do you have any evidence on it? Like that's my retort.
Yeah.
And some people are like, no, I need evidence. And other people are like, no, actually, I was just curious. Because I immediately think they're trolling, but sometimes they're not trolling. They just actually want it.
Yeah.
But I'm like, look, you don't need evidence to be able to do something, because evidence to me it's just going to be disproven. It's just cherry picked anyway. What I like to say is everyone thinks they're evidence based. No one really, unless they absolutely don't care at all, and they're just basically like, whatever, adjusting colicky babies and stuff like that. Those people don't care about evidence at all. But the majority of people who are mixers or just general PTs, they all think they're evidence-based, yet very little of what they're doing is evidence-based, So every single thing that I teach both has evidence and doesn't have evidence. I know that it works. That's why I always go back to, whatever technique you do that's not evidence-based, just make sure you somehow tie it back to the things that we know are evidence-based, which is patient education and active strategies and some sort of like strengthening program, or then looking at other peripheral things like nutrition and sleep and things that you don't always have to do. So I know that that's kind of like a cop-out answer, but there's not
that
just
might be the
one
best
thing.
answer we've had.
I would just say
honest.
It's every single thing that I do and that I teach is not evidence-based, but yet it's also, I tie it back to the evidence of empowering the patient.
Well,
and also telling them, we don't even really know why this works. I just know that it does. You're going to feel better. No one can really tell you exactly why.
Yeah, but that gets, we made that point earlier that you're constantly questioning why, which then hones your clinical skills, which betters your patient education and communication. And it's just, to me, it's kind of like a concentric circle being drawn over time. Like it's never going to end, right? There is no end to that thing, but it gets bigger and bigger and bigger as it expands outward. And that is literally like your vision as a clinician, your ability to integrate the ideas that you're able to hold at the same time that don't compete necessarily, that they work together. And I think that's, the best clinicians in the world can do that. And I think sometimes like people just like literally like, it's like a wire gets crossed, or they blow a fuse because it's like so many things compete, or they lean so heavily on something. It's like at some point in their career, it's just like, this is what I do, or, I'm done. I'm just going to, strength train everybody or pain neuroscience talk everybody out of it, versus other clinicians just like, I'll just keep integrating, man. I just want to keep expanding the circle, which I believe is what you're doing. And that's, obviously why Steve Capobianco introduced us and, to be on the podcast, because I know that he believes that about you as well. So, I just want to say, hey, thank you for being on here and taking time either in between mowing and swimming or whatever else was going on. And also good to meet you, because again, like I was familiarized with you when I was, in school, and I've just kind of stayed on the periphery of what you've been doing from a social media standpoint. So it's good to finally talk to you, meet you, I guess. Any last words for anybody listening, whether it's, patient, layperson, clinician, anything you want to leave us with?
Yeah, just make sure you balance that confidence with uncertainty, because there was a point in my career where I became so uncertain that I wished I could bottle some of that confidence that I had like during the first 5 years of my career. Because like the last 5 words of the overconfident clinician, I would say, is I can help you, I think. Which is pretty much what you think with every patient now. Yeah. And sometimes it's like a simple ankle sprain that I know I'm going to get better. Mm-hmm. And other times I'm like, this should be no problem. Like someone contacts me like, oh yeah, I'm like a 20-year-old CrossFit, female runner. And I'm like, oh, this is going to be no problem. And it turns out to be like a super complex case.
Yeah.
So yeah, I just have like, just balance your confidence with your uncertainty with confidence. And you won't be able to help everyone, and it's okay to discharge people in pain.
Yeah. Yeah. Well, awesome, man. Well, I hope we stay in contact. Maybe I'll make it to course here sometime soon. And
let's swap podcasts. You can come on my podcast sometime and just tell like a quick 5-10 minute story of a big interesting case or a big failure.
Big failure for sure. Those are always more fun.
All right. They sure.
And I'll put links to as many of the websites and main things that
I'll give you the 3 main links.
Yeah.
Just follow me at Modern Manual Therapy on Facebook, Instagram, and YouTube. Or if you're on LinkedIn, just ask to connect me. or connect with me. But yeah, at Modern Manual Therapy,
There
and
you
check
go.
out all my products or courses on Edge Mobility System.
Perfect.
That's the fastest way.
Perfect.
Yeah.
All right, man. Well, I know you're a busy guy, so let's get back to it. And thanks again. And to everybody listening, look up what Erson's doing and find out how to get to be a better clinician. So thanks again, man.
All right. Thanks, Doc.
All right. Take care.
Are you actually going to hang up? Or
I'm going to stop recording.
Okay.
Yeah.
Stop recording.